Well, good evening to you all. For those that don't know me, I'm Alistair Burt. I'm the Executive Dean of the Faculty of Health and Medical Sciences here at the University of Adelaide. I'd like to start by acknowledging the Kaurna people, the original custodians of the Adelaide Plains and the land on which the university's premises here on North Terrace, Waite, Theberton and Roseworthy are built. Delighted that you could join us for the July Health Matters public lecture. And as this is Pain Awareness Week, this evening I'm delighted to welcome Carol Bennett, CEO of Pain Australia. Carol has an undergraduate health science degree and a master's in public policy, and over the last couple of decades she's worked at senior executive levels in national health and aged care organisations and has served on national and international boards and advisory groups. Carol has been National CEO of Alzheimer's Australia, Consumers Health Forum of Australia, Rural Health Workforce Australia and the Victorian Alcohol and Drug Association. She's also managed her own consulting business, working with national peak organisations, and is a current member of the Medicines Australia Advisory Council, Australia Health Practitioner Regulatory Agency National Paramedicine Board, and Director of Lifeline Canberra. So to discuss the politics of pain, making pain a national health priority, I'm delighted to welcome Carol. She tells me that she wants this to be a very much an interactive session, so she's not going to talk for a huge amount of time, but wants this to be an opportunity to have some discussion from the floor. So thank you, Carol, for joining us.
Thank you. Did you want me to use that?
No, I think you
I've got mic'd up. Okay. Thank you very much, Alistair, for that introduction, and welcome everybody. It's a delight to be here talking about an issue that is very important and significant in Australia, and one that is a huge challenge and one that I think we need to create a public dialogue about and see some significant change. I'd like to start by acknowledging the Kaurna people, the traditional owners of the land on which we meet, and pay my respects to their elders, past, present and future. So, the politics of pain. Well, I've worked in various areas of healthcare, mostly leading national peak bodies in the areas of alcohol and drugs, mental health, dementia and consumer health. And in taking on this role, I guess, you know, all of those areas are difficult, but they're easier than chronic pain. One of the reasons I took this role is because I saw it as being a really critical area, a huge challenge, and one that's long been neglected when it shouldn't be. So for me, it was something that I felt needed to be attended to. So I'm hoping I can make a difference in this role. So Pain Australia is an organisation that represents a very broad membership. We've got health, medical, research and consumer organisations in our membership. We're really about advocacy and working to improve the quality of life for people living with pain, their families, their carers, and to minimise the social and economic burden that pain has on individuals and our entire community. We're established in 2011. And our focus is really to work with governments, with health providers, with consumer bodies, funders, education and research institutions to facilitate the implementation of the National Pain Strategy. It's a start-up essentially. We're still growing, and we've grown out of the establishment of the National Pain Strategy. So we're still finding our way as a national peak body, but it's an important mission, and it's one that we're determined to make a reality. So today I want to talk about some key facts about pain, what pain means for people, the barriers to achieving better pain management in Australia, and what can be done. And that brings us to the facts, because when you look at these facts and figures, the thing that always amazes me is just how significant and astonishing they are. If I just pull out one of those facts, the fact that 92% of aged care residents report chronic pain is an extraordinary result. When you consider that 50% of people living in aged care residences have dementia, at least 50%, many of those people have cognitive impairment, they're not able to communicate, they're not able to manage their pain independently, and yet we know that 41% of aged care workers tell us that they receive no training or assessment of pain for people with dementia. So that's extraordinary. 98% of those aged care workers believe it would be really beneficial in their everyday work. So it is something in a variety of settings that we are yet to even begin to challenge, and a very important one. Some of these stats are very old. Our current prevalence data is now 10 years old, and that suggested back then that $34 billion plus per year was the cost to the economy of pain in Australia. Now we know that there's this figure now. If we were producing this research in today's figures, would likely be in the hundreds of billions. So we want to see new data, and we want to see what the impact of this disease really is having, or this condition or conditions really is having on society. A really significant part, or the largest part of that component, is productivity costs. So when you consider that 40% of forced early retirements is the largest component, so people who cannot work for whatever reason usually, the economic burden of the condition could really be reduced if we just invested in better treatment and support. So we have an opportunity to do that. It's making that happen that we need to do. So we know that chronic pain has a huge personal impact, and every time I talk to consumers, that impact is really clear to me. None of these things probably surprise the people in this room. It's often invisible, and patients often feel very stigmatised. There's a loss of function that results in things like less activity, reduced socialisation, less enjoyable activities, and of course all of that leads to disability, inability to work, and then the cascading impact of financial stress can lead to relationship problems, breakdown. In the case of children, many don't reach their academic potential. 40% plus of people with chronic pain have depression. There are really high rates of anxiety, of post-traumatic stress disorder. And suicide ideation and attempts are 2 times greater with chronic pain. So they're very significant impacts physically, mentally, and on somebody's entire lifestyle. So pain is often not directly correlated with something that you can measure or see on a scan. We know that the biomarkers are not always clear. You can have 2 people having scans done on their knee, and you'll see one shows a problem that would indicate that there is pain when there isn't, whereas the other person might have nothing indicative of pain but yet experience pain. So pain is complex. It's not always clear, and it's not always underpinned by some biometric marker or specific disease condition. It's a condition in its own right very often. The personal impact on people, as I said, is enormous. If you take an example, Mary Lynn Cochrane, who often does a lot of advocacy work nationally and for Pain Australia. She's 61, she has arthritis, she's had to stop working in her 20s, so she's had 40 years of managing chronic pain. She's had 22 surgeries over 35 years, and they're really significant invasive surgeries. She's had everything from knee replacements to hip replacements to back surgeries. Surgery hasn't helped her pain. She's still in pain. She has over the years relied on medication, and she took codeine for 4 years and then prescription opioids. 5 years ago, she was finally referred to a pain clinic and she completed a pain education program. And at that point, she was able to replace her medication with cognitive behavioural therapy, mindfulness, pacing her activities throughout the day, meditation and physiotherapy. So she says she's finally reached a point in her life at 61 where she's got better quality of life, and she wishes she'd been able to obtain that much sooner. So it'll stop eventually. No problem. You know, for Mary Lynn, chronic pain is still a daily struggle and something that is a huge challenge for her. And she really works hard. She gets up at 5 a.m. and every morning she does her meditation, she does her exercise, and she goes throughout her day managing this condition. But can you imagine? I mean, one back surgery would be enormous, have a huge impact on any one of us, but 22 of those types of invasive surgeries is just phenomenal. Another case study, Peter, a 44-year-old, he has back pain due to a work accident. He's had 2 rounds of unsuccessful back surgery. He's ended up on a pain medication mix which includes opioids. He, of course, has developed a high degree of tolerance, so has needed to have his doses increased regularly. He's become depressed and anxious. He's had no desire to socialise, and that's had a big impact on his relationships with his family and friends. He's accepted his pain condition, and he asked his GP for help and was referred to a pain clinic. He's learned now how to manage pain successfully without medication. He does daily exercise, stretching, meditation. He tells us that his enthusiasm for life has returned and that he's able to find a job as a result, and he can manage his level of pain. So he's learned to live with pain, as has Mary Lynn. And I guess, you know, again, the impact of this and that pattern is something that both for Mary Lynn and Peter are typical of many consumers that we hear from that have a history of misdiagnosis, of mistreatments, and of years of trying to find what is wrong with them, get a diagnosis and appropriate treatment and support for their condition, but also their individual circumstances. So it's very complex. So, you know, what are the barriers to getting effective treatment for pain? Well, we know, everyone in this room probably is aware that diagnosis is the first step. So, you know, we need to ensure that we have good avenues for people at the very beginning of the process, because the sooner you can get access to early diagnosis of treatment, the more likely you are to have a better result. And as I said, this condition or conditions may not always have a clear physical or biological marker. It does take successive tries of different interventions for many people. It requires considerable time and effort from an experienced health professional, something that's not always well supported by our health system, as I'll talk about in a minute. It's often misattributed to all sorts of other things, whether it's ageing, injury, mental illness, or some other disease. And ongoing pain is often seen as just being something that's reflective of a small number of unresponsive patients. So diagnosis, one of the main barriers, I think. The health system, and I think probably everyone in this room is aware of the limitations of our health system. The quality of advice that you receive from primary care and at that very first intervention is quite important. It can be the deciding factor for outcomes, which is why we think that primary care is such an important place to start when it comes to education and training for GPs, for pharmacists, for all primary care workers. Pain, as we know, and particularly once you get past primary care to a specialist, and you know, most specialists, as we know, adopt a body parts approach to medicine, so they're looking at a particular part of the person. Once you get to that point, the health system is not necessarily supportive when it comes to pain. And just to give you an example, in private practice, a consultant physician attracts a Medicare rebate of $250, while a pain specialist often spends a lot of time with very complex patients, and they have a maximum rebate of $150. So there's a big disparity in how we value the time of a pain specialist. For many people who are looking at specialty practice, you know, that probably makes pain specialty less attractive. And certainly we know for patients, for people who are using their services, the gap makes those specialists very unaffordable. And allied health is also very unaffordable for people. We know that, you know, while you might be able to get access to 5 visits with a psychologist for a pain condition, you know, that's not entirely anywhere near enough. And for many people, and for chronic pain more generally, the gold standard in access to treatment is multidisciplinary care. So, you know, physiotherapy, psychology and the like is very effective for many, many people. So it's very important that we ensure that people do get access to those services if we want to see improvements in the way that we manage chronic pain. So all of those things, I think, funding for pain management is not particularly well supported in our health system, and that's a huge barrier to how we manage people with pain. The third one is health literacy for consumers or patients. It's the consumer-patient experience. Few people know where to start when it comes to pain. They don't know where to find help. Many have never heard of pain clinics and don't know how to access them. When they do, there are usually very long wait times. We know at the moment there are currently only 316 active fellows of the Faculty of Pain Medicine for the entire country. That's not nearly enough pain specialists to address the increasing need for their services. And as I said, wait times can be variable depending on the region, but can be up to 2 years in some places. So it's very difficult to get access to pain clinics, pain specialists, if you are at the higher end of need. So I guess, you know, there's some of the key things that create barriers, but knowing what is doesn't tell us what should be. We know that where you are doesn't necessarily tell you what you should or could do to improve the situation. It just simply describes the situation. We know that there is an enormous mismatch between a huge unmet medical need and the impact on society, but the lack of funding allocations at every level of the system. So this is the same situation internationally. We're not unique in Australia. We know if you take, for instance, research budgets and pain, in the US, the NIH allocates about 0.3% to clinical pain study. In Australia, the NHMRC does not identify pain as a specific category, so it's even harder to identify what percentage might actually be attributable towards pain research. And given how much more we need to know about pain, you know, this would be a really good investment. And given its huge economic and burden of disease, we should be doing more in that area. So one of the problems that I see, and I think contributes to this problem, is the fact that pain doesn't have a home. When I started in this role, there was no place in the Commonwealth Health Department that had pain as its responsibility. There just isn't one. There's no one responsible for pain at a national level in Australia. Pain Australia, until very recently, and you know, I've been in this role now for 1 year, did not receive any federal government funding. The fact that we now are, and we have had some funding from the federal government to be involved in awareness around coding, upscheduling, and we're very pleased that Minister Hunt has seen pain as being a national health priority and has recently allocated funding for the preparation of a national action plan. And Pain Australia is coordinating that work at the moment. That's a great sign. But I have to say, when I look at organisations around us working at the national level to promote, to advocate, to develop policy around really important national health issues, pain is just insignificant by comparison. I mean, the organisation that I was previously CEO of, the Alzheimer's Australia, or it's now called Dementia Australia, receives tens of millions of dollars from government at the Commonwealth level. So there's a big disparity in the sort of support that the Commonwealth government has traditionally given to this area. So I guess with all that doom and gloom, I guess we've got the problem and we know some of the sources of the problem, and I'm not going to provide you necessarily with all of the analysis of what the issues are, and I'm sure you know that that's a starting point for discussions, and many of you will identify many other barriers to how we manage pain. But I think you know, we are currently working on a roadmap of priorities that will look at what we do about this. But I just want to talk in general terms about a starting point for that. The fact that we need a practical runway of priorities that we can present to the federal government. And I think with an election coming up, we should be looking at what we can tell the federal government that they could actually be supporting in this area to advance the condition of people living with chronic pain, because it's a very significant one. It does affect millions of people in Australia, and it has a huge economic and social impact. So some of the solutions, I think, that we need to start by increasing the understanding of pain. I think that'll ensure people get access to the help that they need. Pain is a disease in its own right, a condition in its own right, and we need the community to understand the condition. Health practitioner awareness is also really critical to the equation. We know that we need to better educate and train our frontline in this condition. Stigma is a huge issue. People living with pain tell us that they really have trouble being believed, they have trouble being supported in the community, and it's a huge problem for them to live with this condition. I mean, one of the things that I think has worked particularly well in other areas has been the engagement of high-profile people to the cause and being able to stand out there and tell their story and get the community to understand what the impact of that condition is. I mean, there was a time when I was working at Beyond Blue when depression was a dirty word, and the same with dementia. You know, the community did not want to engage with those issues. They didn't really understand it. You know, there was a huge stigma attached to having those conditions, and I'd argue that the situation with acceptance of those conditions has changed because the community awareness and understanding has changed and improved enormously. And I think, you know, that is critical to changing what governments do as well, and that's critical to getting a much better result. So recently we've engaged Sophie Scott, the ABC National Health Reporter. We've got Sir Angus Houston. When you get people like that of high calibre that are prepared to tell their own stories, in the case of Sir Angus, he talks about his son and his pain condition, and Sophie talks about her own pain condition. You know, that normalises and creates acceptance in the community, and I think that's a really important thing that we need to promote, because we need to change the way that we understand pain and the awareness of pain and how you can manage pain and live with pain in our community. So in terms of the health system, the solutions, you know, are difficult because the health system's not particularly good at changing. If you look at Mary Lynn and Peter's examples, you know, it took them many years to be able to function better. to manage their pain, live with their pain once they'd worked through a variety of options, and they had a much better understanding of what they were dealing with and that the kinds of responses that were appropriate to it for them. As I said, we need better training for health professionals and others, not just in the health system, but in areas like aged care. We need better access to multidisciplinary care. Multidisciplinary pain clinics are really useful. And as I said, there's an inadequate access due to cost and lack of subsidy of those services. I think in some cases the need for referral is often a barrier as well. So there's a huge MBS review underway, and Pain Australia is contributing to that work. That's looking at MBS reform as well as procedural items. I think, I don't want to be cynical, but there's certainly a desperate need to change the way that we approach healthcare in Australia and to change the whole Medicare system so it's more responsive to consumer needs. The problem is that that review is being conducted at a time when we're coming into an election cycle. So the appetite for significant change is not likely to be high, but we're hopeful that there might be some changes that at least enable people with chronic pain to have access to better services and things that will work for them. In terms of consumer and governments, where do consumers go when they have pain? We need to make the options more prominent and more accessible. I think it's really important that we have an actively engaged consumer population. That's really critical and has been, if you look at the areas that have been successful at attracting government support. They've been areas where we've had a very organised consumer population. They can articulate what works for them and be responsive to their needs. So I think we're in a situation where generally consumer voices impact not only on the public attitude but also through them to government. And I think it's really important that as part of that we need to increase health literacy for those who have pain. I mean, how many people with low back pain don't know that surgery doesn't work? It's just, you know, it's changing the understanding, the awareness and how we respond to pain. That's really critical. In order to change government's point of view, it's easy to say what government's not doing. And we know that there hasn't been a lot done, as I've said, to address the needs of people living with pain from a federal government perspective. But I think we need solutions that government can support, practical solutions. We've got a national pain strategy. We've had that now for 7 years. But what we now need to do is get on with the task of creating the roadmap, of identifying the practical priorities. We need to well articulate that and provide government with the solutions that gives them the opportunity to change the way that pain is understood and responded to. So I'd strongly encourage anyone in this room who wants to have their say around the National Action Plan to fill in our survey, to get involved. We're consulting at the moment, and that's something that we're hoping to have done by the end of the year. So I think there is a need for change. We are living in a situation at the moment where I think change is imminent. I think we've got reason to be optimistic. I think if we look at where we are at the moment, pain is a disease in its own right. It's having a massive impact in Australia, and we know that. The individual consumer experience of pain typically has reflected a failure to be able to gain effective treatment or even know what those treatments might be or those options might be. The health system itself has not been particularly responsive to complex, ongoing and multidisciplinary or multidimensional conditions like pain requiring multidisciplinary support. I think it's really important that we have community and health professionals mobilised with the need for awareness and understanding of pain. And I think we can actually make a huge difference in the lives of thousands of people experiencing ongoing pain if we can make some of those changes. I think the first step is investing in a national action plan. The next part of that is advocating very strongly to government about what needs to be done and changing the whole conversation in our community. So thank you Paul Rowland, and thank you Alistair and the University of Adelaide. It's been good to have this conversation, but I hope it's the start of a conversation, and I hope to hear your views about your thoughts. Thanks.
Thanks very much, Carol. So now is the opportunity for some discussion, questions and answers. Maybe while you're thinking what you want to ask Carol, if I could start by picking up what you referred to about health professionals and increasing the awareness in those individuals. So one of my remits as the Executive Dean is the oversight of all of our teaching programs. In particular, we've got a number of clinical programs, medicine, dentistry, nursing and so on. And of course pain is something that is, and approach to pain management is incorporated into those programs to some extent. But if you had any advice for me to pass on to my program directors for that early cohort of the next gen of healthcare professionals, what would it be?
This is core business. I mean, it's absolutely something that we know gets very limited attention at the undergraduate level, and you know, I mean, I guess there's all sorts of demands on people's time. So getting GPs interested in looking at pain and you know, doing extra education and training has always been a bit of a challenge. There are, you know, various other alternatives that they can choose, and pain's often seen as being something that's a bit complex and a bit, you know, a bit difficult. So, I mean, I think if we can improve the public perception of pain, if we can make it more of an issue that is considered part of the mainstream, because at the moment it doesn't sit well within the health system, and I think we need to encourage health practitioners to get involved. They are the front line, and that's where we can make a huge difference.
So one of the things that I picked up on was the importance of taking a holistic view. Your two case studies both had, as part of the solutions they now have for a better coping, is around mindfulness and meditation. Now we do have a pain module in the medical program, and I'm looking at Paul now because I'm not quite sure whether we incorporate that sort of element in it, because I was very struck, but it was exercise, it was mindfulness, and it was...
Yeah, look, I think it's something that it's a question we're asking ourselves. I think in Adelaide we actually have quite a good multidisciplinary immersion in pain. In fifth year in our program, we've got a very motivated group of clinicians. There isn't actually a national... there isn't any standardisation around the medical schools around Australia, and that's OT medicine. And then, of course, what about patients with orofacial pain, dentistry, and so forth. However, even though I think we have a very good program in Adelaide, when we look at our graduates, they're not very skilled. And I think Carol has put her finger on it. It's actually hard. This is something we've got to start training. To think we can do it in one very good week is being a bit simplistic, and it needs to be as embedded right throughout. And so this whole biopsychosocial model needs to be introduced early and then layering it up, because you know, as students, problems that are hard, people are scared by. You know, you've got a rash, stick a cream on. Easy. Squeezy bag doesn't work, give them some pills there. But actually pain is hard, and problems that are hard people tend to shy away from. But of course we do know that, for example, our graduates, even though we think we've trained them quite well, when they come to manage even acute pain as graduates, they're still struggling. Now I know we have a very good program here with 6th year, for example, really helping that. So I think we've got a lot of input, but we're still not getting the result. And I think to recognise that it's hard, and I know our faculty is looking at trying to standardise an undergraduate education. But when you recognise that we have medical programs in Australia that vary from 6 years to 4 years and 8 months, and everyone wants to get their slice of time, how are we going to get a complex and hard message in there? And maybe actually as undergraduates we can't. Maybe this is something that needs to be brought in more, because I don't think you really understand it as a student until you've actually really dealt and talked with quite a lot of patients and understood it at some depth.
Yeah.
Okay, thanks. Yep. All right, thanks. So I'm open to questions.
I can take the mic around if we want to go with it.
Perfect. Yeah.
Just one down the front.
Yes, please.
Good evening. It was a really good lecture. But when you spoke about the problems and how to tackle that, shouldn't one of the solution also focus on getting the patients to accept that pain in itself is a problem? Because personally, like I have lived in pain, chronic pain for 9 years, but for me now, it's become a way of life. Like I deal with it, I wake up in pain, and for me it's like, okay, it's done. And I'm a doctor myself, so I know a lot of options are available. But at a point, I think there's a point where patients don't want to accept that their pain needs addressal. Like there is way where we can reduce the system. So shouldn't there be a component of the solution that focuses on getting patients to accept that being in pain is not a way to be, and maybe they need help? So basically, shouldn't there be a component that focuses on them getting them to accept that they need help? Because there is only so much you can do, but when the patient does not want help, how do you address that?
Yeah, look, I think it's really complicated. And I mean, you don't want to say to people that they should just learn to live with it and suck it up.
Exactly.
It's something you're just going to have to get used to. I mean, to get to the point that Mary Lynn and Peter got to took many, many years and many failures before they got to that point and learned ways of managing. And I guess, many people say to us that stigma is very real when, they're not being believed and they are really experiencing great pain, but can't get people to accept it. I mean, it's a difficult message, and I guess that's the thing about awareness. I think community awareness could go a long way towards helping people accept it's a condition in the first place, understanding that many people do live with chronic pain and they live well with it and can function, but how do we do that and how do we achieve that? What are the examples, the Mary Lynns and the Peters? How do they get to that point that they can manage that well on a daily basis? So it's complicated, and I guess there is that balance between people accepting that they might have to live with pain, or that they need help, or that there are ways of managing it, but also not alienating them by suggesting that that they can learn to live with it and that they just need to get on with living with pain. There's a balance there that we need to be a little bit careful about as well.
Next question there. Paul, you're going to get a bit of running around. Yeah. Okay. There we go. Excellent. Perfect.
Hi, I wonder if I can also maybe make a comment about that. I'm a psychologist who's worked with people with chronic pain, and I guess definitely one of the core components of the treatment is about clients understanding the neurobiology of pain, so understanding that pain is the output of the brain, and as part of that, there's a sense of with clients that a sense of acceptance of that, and understanding then how do the treatments relate to changing the neural pathways or addressing neural pathways. That can often be very helpful. I just had a question in regards to pain specialists and pain clinics. I understand that obviously there's been an increase in availability of chronic pain clinics in South Australia in particular. I wondered if you might be able to speak on further opening of pain clinics in Australia.
Yeah, well, I think one of the challenges is having enough pain specialists, people who are willing to train in pain specialty, having the funding. It's hugely expensive to support education and training of specialists. And that's something that I think we will probably be advocating for as part of a national action plan, that having access not just to pain specialists but multidisciplinary supports around them is really important. And I think it is the gold standard in this area. I think we really have to accept that we haven't done enough to make that accessible, and I think that's got to be part of the solution if we're serious about giving people good options for managing pain. So yeah, I think it's definitely something we want to see happen. It's great to see that the South Australian government has been quite supportive too in this area.
Next question. There were hands up a minute ago.
There's one down here.
Okay. You're up there.
Hi, my name's Mark. I'm one of those people who works in one of those new pain services, and I've just recently moved from working in emergency for almost 20 years into persistent pain. I will get round to asking you a question. And I think my work colleagues who worked with me just went, "Are you crazy?" And that sort of shows what we're working against, even amongst health professionals, let alone society as a whole. My question to you, I guess, is in my short time of working within this field, one of the things that's become obvious is the difference between passive strategies versus active strategies in managing pain. And what we find is that obviously those active strategies and promoting those is what works best. Has there been any thought to sort of, I guess, try and promote that as a message? Because for me, I think that's a key thing, and that covers sort of the acceptance and etc.
Yeah, look, I think that's a key issue because, I mean, we've often been taught, you know, as children that the thing to do about pain is to, you know, go into a dark room, lie down and, you know, take a pill. So the passive sort of strategies are just ingrained in the culture. And we saw a lot of that when codeine was being upscheduled. People just said, look, you know, I just need to take this and go to bed and stay in a dark room. And we know that, you know, very often they're not the things that will actually work, and we need to get people moving. We need to get them to do the things that will actively manage pain. I think it's a cultural change, partly, and that, again, comes back to community awareness and just that understanding that, you know, pain and how we manage pain and the whole way we think about pain needs to change. And I think the codeine issue, I mean, it was a difficult public conversation, but the resistance, I think, was indicative of people's long-held beliefs that, you know, you manage pain in a certain way. And to change that, you know, I think we started the process. I think we've got a long, long way to go. And it's difficult, it's complex. And I think those messages that you're talking about are not well supported by our health system either. So they're the things that are much harder for health practitioners to do. So we don't tend to do them as often. It's not part of our health system. It's not part of our public conversation or our culture, our understanding. So we've got a big task. It's a big challenge. But I think we're starting to see a bit of a change in that understanding. We need to do a lot more to create that. But great point. Thank you.
One there and then down here.
This is a question sort of regarding medical school. If we need more doctors to really understand chronic pain, is there any way we can make it easier or make accommodations for people who actually live with chronic pain or who have other disabilities to study or train to be doctors?
It's a good question. It might be one for you, Alistair, I think.
You know, I don't think it relates to pain. I think the problem is most young trainee doctors come from quite healthy middle-class backgrounds, and I've fantasised it'd be nice if we could randomise people to suffer a serious illness reversibly, so that they could actually experience this. But you know, obviously.
I'll give some context. I was applying for medical school and had to turn it down because of my chronic pain condition.
Well, I'm sorry to think, because unfortunately medicine is a hard course to do, and you do need that strength. But the question is, when do you acquire empathy in your career? And the problem is, look, I started medical school at 16. didn't no idea what was going on. We've got an argument, maybe we should be taking more, other medical schools take people at a mature age and so forth, but actually you can, we've got a superb faculty and we do try to do that, but only by talking to lots of patients do you really understand it. So I think we need to look at the training people go through, and you're absolutely right that it would be ideal for students to have some insight into this, but you could argue that then we should actually be taking, there are quite a lot of other experiences that people, that they should have. But given its pain prevalence, it would be useful to have people who have some of that insight. But of course, you've still got to make sure they can do all the rest of the job as well. And sometimes over time, you just, by talking to lots of people, as my colleague Mark mentions, you sort of grow into it. You might not have it when you start, but with good mentoring, you get taught how to listen to people. And you may not have that same experience yourself. And I would actually like us each to have would like to give every trainee doctor a bit of chronic pain for a bit so they could experience it, but I think there are a few ethical issues in being able to enforce that in there. But that fundamental question of how do you get empathy and insight is one that all of us who teach medical students want to know, because they come in wanting to do a good job, but there are different backgrounds and so forth to be able to help that. So we know it is hard, and it's one of the arguments I think of having a relatively long medical course is that you can actually take people, and it's an argument why, rather than the science and then going to medical school, you just teach people how to diagnose. One argument in favour why we still have a long medical course is so that we can try and really build those values, empathy, a lot of patient contact into the program. So that's why, one of the reasons why the University of Adelaide hasn't gone to a graduate model. We have still one of the longest programs, not because we're inefficient, but because we try to produce really good graduates. There was a question that you've been waiting quite a long time, I think, down the front.
I'll pass it in a minute. Just to follow up on that, one of the things about medical training in general has been the model is that you see stuff as it comes through in the wards. And chronic pain, you're not going to see that track over time if you're just getting a snapshot. So increasingly we're trying to introduce a longitudinal experience for the medical students. Our students who go into rural sites get a lot of this because they're in a site for a whole year and they get to see patients on multiple occasions, whereas the traditional model has been just getting a snapshot. You're a doctor, you probably had experienced that as a medical student. So I think we are recognizing that understanding those more complex problems, not just pain, but other things that have multiple inputs, that is something that you will best understand, not just in one snapshot in time, but over a period of time. Thank you.
Hello, for the benefit of the audience, I'm an undergrad student, a third year pathology student, and a lifelong chronic pain sufferer. I started in my childhood and with mobility problems, and by the time I was 14 I was incapacitated mobility-wise. I didn't seek treatment for many years because it was a taboo thing, you just had to get on with it. And once I got married, this wonderful man here financed a lifetime of musculoskeletal therapy, which gave me mobility, kept me out of a wheelchair. And by the time I was in my mid-30s, let's be clear, there's a difference between pain and suffering. There are days when I'm in acute pain, but I don't feel that I'm suffering. And there are other days I'm crippled from the emotional toll that this has had on my life. And so on top of all of those therapies that I've engaged upon that keep me functional, there are moments when I just need a break. And I'm disturbed at the lack of the mention of medication in this presentation today. I'm really glad that you've done it. But I'm even more concerned that the government decided to take away autonomy from GPs who know their patient, have got a long, good relationship with their clients and patients, and decide, yes, you deserve endone. Yes, you deserve that because you have done everything else that the entire system recommends, and there is still a gap in your ability to function, and we want to help you alleviate your suffering. And then the Health SA sent a letter to my GP and stripped me of medication. I am doubtful I am now going to finish my degree as a result. And I am approaching 50 and yet to feel a productive member of society.
Yeah,
It's not fair.
I mean, it's thanks for sharing that. I mean, it's medication is a really difficult issue at the moment. It's one that there is a review around opioids. I assume you're talking about an opioid medication that the TGA are doing. It's a complex issue. It's something that we're concerned about for this very reason. There are unintended consequences of, taking a really blunt regulatory approach to medicine, particularly when it comes to chronic pain. I mean, we know in general. Yeah, they do. Yeah, yeah, we've seen that. Yeah, yeah, and we have seen some examples of, even end-of-life care where there have been instances where medication has been withdrawn, and that's just silly. But I think it's a conversation we're having at the moment. We've certainly pointed out from a Pain Australia perspective that we need to be careful of unintended consequences. We know at a general level opioids are not recommended for long-term chronic pain, but it should be also the case that we allow the doctor to decide and have that conversation as well. But it's complex, and there are, we've seen what's happened in the United States, and I guess, there is a concern that we might end up with the same sort of issues here, but complicated issue, but yeah, very difficult.
Well, one very last question. Sorry.
So in regards to the National Action Plan you mentioned and the awareness that Closing the Gap policy also doesn't address pain specifically, if the solution, as you mentioned, begins with where the patient is, focuses on their needs and ideally should be multidisciplinary, is Pain Australia exploring the inclusion of traditional Aboriginal healthcare in the action plan, considering the mechanics of this model differs to the medical model and is incredibly effective with pain experiences? Yeah,
look, that's a really good question, and in fact, we have started a conversation with NACCHO, the National Aboriginal Community Controlled Health Organisations, because pain has not really been well articulated in any of the responses, and certainly, we were at one of their launches recently of a health management report that they put out, and was saying, well, where's the mention of pain? And what they were talking about in all of the approaches that they had set out in that document was really many of those involved pain management, but it's complicated. Again, it's an area that is a challenge for that sector, I think, as well, and hasn't yet been fully addressed from what I can see. And it's something that it did come up recently. We had a national roundtable to look at a refresh of the National Pain Strategy now that it's 7 years old, and that issue came up that we actually need to be looking more at Indigenous health. It's a huge issue, we know, in Indigenous communities, and we need to articulate that, but we're at the very beginning of even starting to understand what that means and what the appropriate responses should be for that area. So, very good point, but yeah, you can't say we've achieved anything that we should have at all in that area at this stage.
Okay, well, I think we'll need to draw it to a close. So, Carol, thank you for an excellent presentation and the opportunity to have this question and answer session. It's clear that pain is a huge societal issue, and you've outlined some of the current challenges, but also presented some thoughts as to at least some solutions to overcome those challenges. It is clear to me that you personally and Pain Australia as an organisation are committed to elevating pain as a health priority, and you're beginning to get some traction with federal government. You did hear, ladies and gentlemen, an invitation to contribute to that development of the action plan through the consultation exercise. So I would encourage you to do so, but then finally ask that we all thank Carol most sincerely for a fabulous evening. Thank you.
Thank you, Alistair.